Good morning. A little anticlimactic after we gave away a car. Did I win the car? Yeah. Gerald? Okay, good. Kristen spoke yesterday, and I just want to welcome everybody back again this morning to our symposium. And Kristen is at the University Hospital in Jacksonville, Florida, where I did my surgical residency, and I asked her if they were still talking about me. She said they don't know who the hell I am, but that's okay. That's 107 years ago. So, but I'm delighted that that institution is still doing a lot of trauma, I suspect. At one time, it was one of the busiest trauma centers in America. How about that? So, Kristen is a clinical quality nurse leader, which means that a lot of people are either mad at her or scared of her all the time. But she has a bachelor's degree in nursing. She's been working in emergency departments, starting in Jacksonville. She was at shock trauma for a little while, which is home central for trauma in America today. She's been a trauma registrar. She has a great deal of experience. She is steeped in trauma, and this morning she's going to talk about special needs. And I'm just delighted that she's here, and you can tell everybody that I'm still well known.
I will. I'll let them know when I get back. You guys hear me? Okay. Good morning. I know it's early, right? I just want to thank everyone for having me again. I really have enjoyed. This is a great symposium. I've been to a lot of different ones. This one's awesome. You know, there's a lot going on. And the food, right? That's always sells it. That's how you get a nurse's heart, is you feed them, right? That's where like, yes, we got pizza last night. All right, so I'm going to talk about outside the norms when trauma strikes special, unique, and special population. So here's some learning objectives. You know, we got to have those, right? So I'll give you a couple of minutes to review them. Again, I have nothing to disclose. I am here on behalf of UF Health. Again, I hate the color of these slides because it's orange and blue, and I feel like everything should be garnet and gold because I am a Florida State fan, but it's something I have to deal with. That's a personal issue. I am here representing them. Oh, did I just see oh yeah, let's go Knowles. All right, so I was going to let you know too that the honorarium that I'm getting, I mentioned this yesterday, I am donating it to the hospital, specifically to my nurses that are at bedside, so that I can send them, hopefully NCI's in Orlando next year, so that's super close to us. So I'm hoping to send 3 to 4 nurses. That's my goal. We were unable to financially send anyone this year, and that's a bummer. I think they deserve it. They work hard. So that's my only disclosure. But if anyone wants to pay me to do something else, we can talk later. I'm always willing to take donations. No. Anyways, let's talk about the scope of this problem. So about 1 in 60 people have autism. There's some form of on the autistic spectrum, right? About 2 to 3% of the population is intellectual disabilities, and it seems like a low amount if you think about it, but that probably means that we're not identifying them, and they could be we're even less familiar working with intellectual disabilities, right? We're not as good at it because we don't see them all the time. Cerebral palsy is another one, and there's a couple of others here listed. It could be from a spinal cord injury, blindness, deafness, speech disability, short stature, Tourette's, seizure disorders, things like that, psychiatric disabilities. These all kind of go up underneath this unique population. So this was a study that was done in 2012, so it's a little old now, but it actually talked about, it surveyed a pretty large population of special needs patients and their interaction with nurses. How do you think that went? Not well, actually. We kind of stunk at it. And nurses, we pride ourselves on our patient satisfaction, right, and how well we take care of people, but we actually didn't do that good of a job, all right? Poor communication by the nursing staff. There was compromised care or lack of competency, they felt like. This is per the patient. Negative attitudes, they felt like they were second-class citizens. Fear related to their quality of care. That's not cool. None of us get into this to hurt somebody or make them feel bad, right? They already feel bad enough, they're in the hospital or they've had a traumatic injury. So this is not a good thing. How many of us do this? I've done this, I'm guilty of it. If I think there's some sort of a intellectual disability or even my elderly, I like scream at them, my voice gets really loud. Does that mean they're deaf? Not necessarily, right? I talk fast, I talk over people all the time. It drives my husband insane, he can't get a word in edgewise. Not that his word really matters that much, but anyway, so, but I talk over people and I don't give them enough time to respond. And sometimes with these patients, you need to give them a few minutes to get their thoughts together and to be able to get that out, right? No one should be fearful of their quality of care when they come into our institutions. That, I feel, is and be felt like a second-class citizen. So why does this matter? Well, because of the patient themselves, it should matter. Because we do this because we want to help people, not hurt people. But let's be honest, healthcare now is all about reimbursement. Anyone get the fun of looking at HCAP scores regularly? Yeah, those are good times. Okay, in the SICU where I work, we have 28 patients. Pretty much, most of the time we run about 17 to 20 ventilators each shift, each day. Most critically ill. Do you know how many people we discharged from our unit? We did 6 in 4 months. Do you know how many people responded to our HCAP scores? 1. Hey, we were great. We were all in the green. I was like, this is awesome. Look at that unit. They had 300 and something discharged, but we're all in green. But it's not accurate, right? But this is how we're being reimbursed now, right? This is how the government's funding us and deciding which hospital they're going to give money to. So this is important, right? So every patient, it makes a difference. So let's talk about autism. It's a huge spectrum, right? Because you can have somebody who maybe has Asperger's, which is more of like a social disorder, all the way to an autistic child or an autistic adult who's nonverbal, and it doesn't mean that they don't understand necessarily, they just may be nonverbal. And so there's this nice little diagram, and all of this kind of goes into the autistic spectrum. They can be very challenging patients to try to communicate with and to try to understand what they need, right? Behavior can be an issue. Because they can't communicate, what do? They act out a lot of times, right? Because that's their only form of communication. So that's something we have to keep, in the front of our minds when we work with these patients. So, like I said, communication. This is a nurse at Shock that I work with. She's still there, Megan. She's great. It's such a good picture of her. Anyways, so language. Is their language delayed? Or do they even have a form of language, right? Can they even communicate, like I said? It's a big problem. Most of our patients and most of the things we do, it all boils down to communication. If you ever do any PI work, you get to go back and look at stuff, it almost always comes down to communication. What about this guy? Anyone ever seen him? You think he's got some social awkward issues? I love that show. He cracks me up. Anyways, nonverbal behaviors, right? They may have issues with their peer relationships. Joint attention, social reciprocity. Every time I say that word, I get tongue-tied. All right, so this is a trauma bay at Shock. Most of our EDs and trauma bays look like this, right? What happens when the patient shows up? We all ascend on them, and we strip them down to their birthday suit, right? We take everything off of them. We take complete control of the situation. It doesn't matter if they're awake or not or whatever, right? This is scary for the average American who doesn't have a disability. Anyone had the pleasure of riding on a backboard in the back of a rig and then showing up to a trauma bay and all these people show up and then they strip you naked and then you're cold and then you're like, what's going on? And they're poking me with needles and sticking stuff on me. It's not a good time. I got better things to do, right? I'd rather not be there. But imagine looking at it through a disability. Now it's kind of warped. Now it's even more intense. So we have to keep that in mind. So what do? So the best thing to do with these patients, and again, it all boils down to communication. Of course, your ABCs, right? If they're critically ill, you got to do what you got to do to save their life. But if you have the time, and if EMS picks up on the way in, hey, I think there's some sort of, some intellectual disorder going on here, or the family member reports that, they have autism or whatever information you can get prior to coming in can help you prepare. So maybe not have the bay full of everyone and their mother, and because I know trauma is a spectator sport, right? Everyone shows up. There's people from places in the hospital you didn't even know existed. The IT guy comes from across the street because he heard a level 1 was coming in. I heard the helicopter, right? So this is not the time to have a spectator sport, right? Crowd control. Maybe try the primary person who's going to be at bedside as the nurse to be the primary communicator. If they have a family member that they're comfortable with, right? Having that person be there. Make eye contact. That's a big one. We don't do that very well in general, right? What are we all doing? On our phones, right? Or yeah. Eye contact is important. I'm guilty of it all the time. I'm looking at my phone for stuff, But taking that time so that they know that you're there, it's comforting. Calm voice, not excited. I love me a level 1 recess too, I'm not gonna lie. Because sometimes you gotta be that person to kind of be calm. Also, if you can forewarn them before you touch them. Like, hi, I'm Kristen, I'm your nurse. I'm gonna put a blood pressure cuff on you. Don't just grab the arm and throw it on there, because especially if they have poor communication, what kind of behavior might you see? A good swing, right? Don't touch me, right? I don't blame them. They don't know what you're doing. So we gotta tell them, we gotta have that time. Explain what they will feel. This is not the time to say an IV is a bee stick. Anyone been stung by a bee? An IV feels a whole lot worse than that, right? Be honest with them. This is gonna hurt. I have to draw blood. But it's all in how you say it. This is gonna make you better. How do you wanna lay your arm? Try to help them, make them participate. Very similar to how you would with kids, but don't talk to them like a child, right? Be honest. I think that's in general, be honest with your patients. Don't say the CT scan's gonna be back in 30 minutes when you know it's gonna be 4 hours later. Or you're up next in triage, right? Because you know that's not true. Because it just depends upon what rolls through that door next, right? Make them feel safe. Make them feel like they're in a safe environment, all right? They've left the comfort of their own environment. And environmental changes can actually cause them to feel more angst and more anxiety, okay? Because it's the unknown. There are some great assisted devices out there nowadays. Thank goodness for technology. This is an actual chart. That's a pain chart that you can use. I know in Maryland, there was a lot of work with Baltimore City to have them start carrying these in the rigs because of the fact that they realized that there was some issues with communicating on scene. And so having some of these charts and things was helpful. So this is just one chart. The iPad, if anyone's worked with any kind of autistic, especially children, you see a lot of research on autistic children and things. It's actually the iPads and the apps is great. I have a good friend, she's a nurse, her son is extremely autistic. He's on the far end of the spectrum, he's nonverbal. The apps have made his whole world different. He's 10 years old, he was not potty trained, she was having lots of issues. She started using these apps and some of this behavioral stuff, and they're able to accomplish a lot. And he's now able to actually communicate what he needs. So these are great. There's some free ones, there's other ones, this is just one in general. So they're really great. Okay, let's talk about cerebral palsy. I have a cousin who has cerebral palsy. She is wheelchair bound. Not all are wheelchair bound. But a lot of times they have jerky movements because of the rigidity of their muscles, right? So she does. Slurred speech, that's very common. One of the things that happens with her is that her eyes have a hard time focusing. So you're looking at her and her face might look at you, but her eyes are kind of drifting and they'll actually drift opposites. You know, it seems kind of weird. Sometimes they move back and forth and you might think, oh, is she having a seizure, right? So sometimes there's slurred speech and there's delay in speech. This is where you give them time to answer. So you ask a question like, how is your pain? Intellectually, she's 100% there. She can speak, but you have to give her some time to actually explain, to actually talk. So sometimes they appear like they're drunk, or you're like, what is going on with this person, right? Mm-hmm. Don't always act on your first impression. We're really bad about that, right? Oh, that's the drunk guy again. Oh, that's the whatever. Don't do that, right? We need to actually figure out what's going on, get all the facts. It is helpful if there's family or friends or a caregiver there to help fill that in, but as we all know in trauma, that doesn't always happen. Listen, give them time to answer. Don't take away their assisted devices. Kind of like I talked about the prosthesis yesterday. They like to hold on to them in my ED, right? Same thing, that's their form of mobility, right? So if I take away their cane or their walker or their AFOs, that's their way of them being independent. And now I've taken that away from them and not allowed them to use it. Now I've taken away their form of independence. I love Lauren, my cousin, but she sometimes is a little socially says things that I would consider awkward. So don't be offended if they say something that seems, yes, she has told me, that dress is tight. Are you fat? She said that. I was like, oh, never mind, okay. Right? She's just being honest. It's like a child, She's just being honest. She doesn't have that. A lot of it, because of her disability, that social interaction is delayed. So that's some of it. All right. So I'm going to talk about a specific patient that a nurse that I worked with, Bridget, took care of. I was there that day. And so it was a high-speed crash, multiple rollover. This was when I was in Maryland. Her arm was partially amputated. You guys are going to think all my case studies have to do with like amputations now and stuff, but they really don't. And left open humeral fracture, okay? So she arrives. This is her x-ray. I'm not a doctor, but I'll say it's broken. Those bones don't lie up. It was a very strange, normally you would expect a young woman rolling in would be screaming and crying, and there was nothing. It was a very flat affect. It was very strange. We didn't know what was going on. We were like, it just seems weird. Like, she's not really responding to us. She was by herself, so she'd ask questions, but it took her a few minutes. She was a little delayed in answering, and there was a lot of yes, no type answers. She had this, I don't know how to explain it other than her, like, she would just like lay there. And you'd be like, okay, we're gonna do whatever. And there'd be nothing, and you'd be like, most people would be like, okay, thanks, or, oh, can I get some, more pain meds, or nothing, okay? But we really didn't have time to mess around because that's broke. So she was in the OR pretty quickly. She got scanned, nothing else was wrong. She made it into the OR within 39 minutes. Here it is, all fixed. Looks lovely. It did great. She was able to keep her arm. We didn't find out until later, when her family finally showed up, that she had a history of hypothyroidism and she had Turner syndrome. It's a really rare disorder that affects females, and it's a sex chrome abnormality. So we're all like, Turner syndrome? What is this? I've never heard of this, So we did some research, and we all looked it up, and this is some of the things. They can have hearing loss, hypothyroidism. Well, that makes sense, right? Liver function abnormalities, renal abnormalities, cardiovascular disease like hypertension. She was young. She was in her early 20s. She did have hypertension, diabetes, autoimmune disorders. But she was of normal intelligence, but she had a hard time verbalizing, and that is part of the Turner syndrome. She had impaired nonverbal skills, social cognitive problems. Well, that explains the flat affect, the inability to actually talk to us, right? It might have been nice to know in the trauma bay. I mean, it was only 39 minutes in that trauma bay, which is actually a long time. But it would have been nice to know these things because maybe we could have comforted her better. We didn't. We didn't assume anything, and Bridget, who is the primary nurse, is great. She's very motherly to her patients, and they love her. But